IAP Karnataka State. He's the director of New Amrita Children's Hospital and presently also the professor and head Department of Pediatrics, Navodaya Medical College, Raichur. He's also the EB member of Central IAP 2024. So, and if I go on, probably the whole class would would be needed to introduce Dr. Sanjeev. So that is about the Dr. Sanjeev.
And Dr. Anupam Sachdev, sir, कुछ बोलेंगे sir अभी?
Sir.
Yes, Dr. Anupam sir.
Sorry. I welcome Dr. Sanjeev Chetty. Dr. Chetty, my relationship with Karnataka branch goes back to 1990. When I first attended my first pedicon in the year 1990, when Suresh Rao Arur was the organizing secretary. And incidentally, I got the James Flett Award in that conference. And since that time, my association with Bangalore has gone stronger and stronger, and especially and with the Karnataka people also. I mean, you may take it in the lighter vein, but my worthy opponent was also from Karnataka when I fought the presidential elections. And that makes the ties even more stronger and sweeter. Also, I was the president of the IAP at the Bangalore conference in 2017. So it's always a pleasure meeting Kannadigas and being there with people from Karnataka. Welcome, sir. And I would say that today the reins of IAP are on you people who are younger, and we hope that it reaches greater heights under your guidance. Our next guest is Dr. Patil, who comes from a small city, a rural area, and he is the director of the Amar Hospital. Am I correct, sir?
Yes, sir.
And one thing which I would like to tell you is that he's a Corona warrior, because he was involved in the care of COVID patients, and during that period he gained a lot of fame and brought honors to himself and to the healthcare workers. I would not say only doctors, but all healthcare workers, because during that period, all of us worked like, one hand and like a fist of a hand, and we really delivered the goods as far as possible to the humanity. Our third person who I would like to introduce is Dr. G.S. Narang. Now, Dr. Narang comes from my, as I say, from my Janam Bhumi. My Karam Bhumi may be Delhi, but my Janam Bhumi is Amritsar. I started my career from Amritsar Medical College, did my MBBS there, and moved ahead and came down to Delhi after that. Welcome, sir, from my Janam Bhumi. Dr. Narang is a well-known personality in the whole of Amritsar, and he has won the Best Teacher Award at his university and gained real proficiency in the field of pediatrics, and not only in pediatrics and other parts also, because he is also the literary in charge of IMA and other this thing. So his writ runs not over pediatrics. He's an MD from PGI Chandigarh, and his writ runs even over religion and over literature. Now coming to Dr. Krishan Chugh, all that I can say about Dr. Krishan Chugh is that he is one of my mentors. His guidance at the right time and the push at the right time at various parts of my career put me in the right place, because in the 1990 conference, when we were thinking of writing papers, I had taken the onus of doing too much as usual. And when we were about to send the papers, the chief asked him, "What is the situation of the papers?" So at that time, he pushed me in the right direction, and I was not able to deliver at that time. But then, with his guidance and his push, I managed to deliver the goods. So thank you very much, Dr. Kishan Chugh, a towering personality, as Dr. Alok Bhandari said, and a person who is known for his work in pulmonology, pediatric intensive care, and also for his organization capabilities. I worked under him as the organizing secretary for the 2015. He was the organizing chairperson, and what a fine experience it was to work with him during that period. So, with these words, I think if anybody else wants to say a few words, can come ahead, and the others can start with the
सर
faculty lecture.
सर मैं थोड़ी सी लिबर्टी लूंगा. आई ऑल्सो
Sir,
वेलकम डॉक्टर
बिल्कुल.
ललन भारती here.
Okay.
And one more thing, sir, this year our CIAP has taken a lot of public initiatives under patronage of Dr. Basavaraja sir. And I'm happy to share with you that Dr. Amresh Patil and Sanjeev Chetty, both of them are right and left hand of Dr. Basavaraja for this campaign. And they are the people at background boys, yeah, backroom boys, I can say, who are shining for the shining glory of IAP, that it has emerged in these 3 months of Dr. Basavaraj's tenure. And I have no hesitation in saying that these two boys, younger lot, is also at the forefront. And in that capacity, I also welcome Dr. Amresh and Dr. Sanjeev Chetty. And Dr. Amresh, before you joined, I just shared with the house that we are the academic capital of IAP also, with
Yes, sir.
38 institutions imparting PG classes. And we really heartily welcome you to this platform. And if you want to say a quick comment, please, Amresh.
Thanks a ton, sir, for the hearty welcome. I'm overwhelmed to be amongst the downs of IIP, who's who, and thank you for giving this opportunity. As you mentioned, we are not each, and it's a public initiative of IIP, dream project of IIP, because whatever we are is because of the children of this country, and IIP is for children, the welfare of the children of this country. So IIP ki baat community ke saath is a wonderful initiative. I request each and every person of IIP to take this initiative so that it reaches from the academic capital to the rural capital down south. Thank you for this wonderful opportunity, sir. My pranams to all the doyens here present here. Thank you for giving me this wonderful opportunity, sir. Thank you.
Thank you, Amresh. And Dr. Chetty, now your quick comments, please.
Dr. Bhandari, sir, just a word about Amresh, I would like to say.
Please, sir,
Sure.
go ahead, sir.
Amresh is a wonderful person. He has been doing the wonderful social work in the rural villages. You know, he's going organizing camp, and there's IAP ki baat community ke saath. He's one of the front person who is leading this campaign and working in the rural villages. So I really compliment him for that. His activities doing for last so many years. So welcome, Dr. Patil and Dr. Sanjeev. As you already said, they are both the backbones of the IIT working with Dr. Basavaraja.
Thank you, sir.
Dr. Chetty, please.
Chetty, sir.
Good evening, everybody. I think it's a unique opportunity to come forward before you amongst all doyens of IIP Delhi, and it's been great to be amongst you in this evening. And without taking much of your time, I think we'll have to hear from one of the tallest personality of IIP Delhi and one of the tallest pediatrician of the country, Dr. Krishan Chugh. In fact, in one of the campaign when Basraj was contesting, in fact, I called Dr. Krishan Chugh incidentally for the campaign because I have got the list of IIP Delhi in that. अरे बसराजा के बारे में क्या बोलते यार, छोड़ दो, दूसरे लोगों को तुम कॉल करो बोल के वैसा. I think sir could remember me. I mean during that campaign. Anyway, thank you very much IIP Delhi for bringing Dr. Amresh as well as me and before you. Thank you very much, sir. And over to Dr. Krishan Chugh for this.
डॉक्टर चुग सर 1 मिनट और वेट करना पड़ेगा क्योंकि आपके पेट क्रिटिकल केयर के ही डॉयन जो आजकल हमारे स्टार हैं डॉक्टर नारंग सर, ही इज ऑर्गेनाइजिंग पेट क्रिटिकॉन एट अमृतसर एंड वर्किंग वेरी हार्ड फॉर इट। और आप देख ही रहे हो हमारे दिल्ली में भी कितने फ्लायर पेट क्रिटिकॉन के घूम रहे हैं आजकल। लोगों ने यही पूछा यार इसमें आईएपी दिल्ली का लोगो नहीं मिला। मैं क्या, आईएपी दिल्ली का लोगो हमारा नारंग भाई है ना। तो दैट जी गुरशरण इज, हमें बिल्कुल यही फीलिंग आती है कि हमारे दिल्ली का ही बंदा है। तो इसलिए दी आर पुटिंग एग्रेसिवली ऑल द फ्लायर्स ऑफ पेट क्रिटिकॉन एंड आई एम श्योर डॉक्टर चुग विल बी ए स्टार स्पीकर ओवर देयर ऑल्सो। तो डॉक्टर नारंग आप और चुग साहब अब पेट क्रिटिकॉन एंड आज की सेप्टिक शॉक की बात करें।
हाँ जी, हेलो सर, गुड इवनिंग।
Good evening.
हाँ जी सर, आई एम फीलिंग ऑनर्ड to be a part of this esteemed group, and at this platform I want to welcome all of you to Amritsar for the upcoming North Zone Pet Criticon also. It is on 27th and 28th of April, Saturday, Sunday. So I welcome Dr. Krishan Chugh, the star of today's group, and sir, kindly start the.
Okay, thank you everybody, and thanks to IAP Delhi and Dr. Anupam Sachdev and Institute of Child Health Sir Gangaram Hospital for giving me this opportunity of not only delivering this talk but also opportunity to see and meet, even if virtually, Dr. Amresh, Dr. Shetty and Dr. Narang besides my Delhi colleagues. Thank you very much. So we'll start with our presentation today. The topic is septic shock, and septic shock is in a way very good topic to take because this is something which is coming, which has been kind of updating itself very recently. There have been big updates in this. In fact, 2024 there have been updates. So let me see if this is the wrong one. ऐसे भाई इसकी जगह दूसरा कैसे करेंगे? I seem to have picked up a wrong thing.
स्लाइड शेयर पे जाइए।
हाँ, स्लाइड शेयर पे तो है लेकिन वो ना गलत वाली स्लाइड खुली हुई है।
एक बार दोबारा लॉग आउट करके दोबारा
लॉग आउट करके इसको बंद करो और फिर लॉग इन करो सर।
फिर दोबारा ज्वाइन करेंगे फिर हो जाएगा।
लॉग इन लॉग आउट करना पड़ेगा।
यस सर,
को लगता है लॉग इन लॉग आउट नहीं करना पड़ेगा।
स्लाइड शेयर बंद कर लीजिए सर।
स्लाइड शेयर बंद करके फिर से कर लीजिए सर। इसमें दिख तो रहा है सब ठीक सर।
है तो सही, वो कहाँ है? अभी मैंने खोली थी भैया, कहाँ गई?
सर डेस्कटॉप पे ही होगी सर।
ये वाली है भैया, वो आ गई क्या?
नहीं सर, डेस्कटॉप नजर आ रहा है।
डेस्कटॉप नजर आ रहा है?
हाँ जी सर, अब आ गई सर।
चलो बस अभी जो ये अलाउ करता मैं ये करता हूँ इसको
फुल पे कर दो सर ऐसा।
वो कह रहा है भैया मेरे इससे निकली, वो कह रहा है डेंजरस है, बताओ क्या करें। आ गई इस पे कि नहीं स्लाइड?
जी सर आ गई सर। स्लाइड सॉर्टर आ गई सर, फुल
चलो,
स्क्रीन। ठीक है सर।
Okay, so we shall move to the slide number 1. First thing is, what is septic shock is what has to be decided. Now, recently there has been a lot of discussion on it, lot of changes, lot of guidelines have come. In 2016, this was the guideline that came, that sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection. Very good. Then septic shock is subset of that sepsis with circulatory and cellular metabolic dysfunction associated with higher risk of mortality. Again, very good definition, but the point is, can we apply it to the bedside? So a better definition that way could be, it is defined as a complex clinical syndrome in which the cardiovascular system fails in its primary function of substrate delivery and metabolite removal, resulting in anaerobic metabolism and tissue acidosis. So this is somewhat more clinical. Another one is that it is a condition where perfusion to particular organ, tissue, bed, or whole body is not enough to meet the demand. And what are those demands? Either it is demand is high, but perfusion is normal. That means in spite of normal perfusion, which can happen in septic shock, because the demand has gone high, there is a discrepancy. Or demand is normal, but perfusion is low because of, let's say, cardiac output not being good. Or it could be a mixture of the two. So this is one background. But earlier on, it was said that low BP is not necessary for coming to a diagnosis of septic shock. However, in January 2024, that is just two months back, a new definition has come which is applicable to pediatrics. I'll come to that. It includes that one of these three things, low blood pressure, a lactate of more than 5, or a current requirement of a vasoactive agent, is an intrinsic part of septic shock by this definition. Of course, there has to be background of sepsis. And this is what the current definition is. That there is variables are respiratory, cardiovascular, coagulation, and neurological. 4 variables have been taken only. They considered 8, but out of that, when they were applying 8, including hepatic, renal, and so on, the result was same as if you were applying these 4. So to make it simpler, this is the definition that has been given by a consensus. And what it says is, let's look at the right lower part of the slide in this red covered area. That sepsis, when there is suspected infection, and this is called a Phoenix sepsis score because the conference was held in Phoenix. When the total score is more than 2 points, it will be called sepsis. That means if somebody has a PaO2 F5 ratio of less than 400 and a let's say a coagulation disturbance of platelet less than 1000, it is already 2 points. And now if we add 1 point from the cardiovascular side, it becomes septic shock. So 2 points from number 1, number 3, and number 4. And after this, if the blood pressure is lower than this limits, that means for 1 month, less than 1 month, if it is between 17 and 30, we'll get 1 point. And if it is less than 17, it'll be 2 points. And for example, let's take a child who's 5 years old. At 5 years, if it is the mean arterial pressure is 45, it is 0 points. 36 to 48 is 1 point, and less than 36 is 2 points. So normal values have been given, and accordingly you give them points. And then we go back to the previous slide and see whether we did have a background of sepsis, 2 points from 1, 3, and 4, and at least 1 point from this cardiovascular. And cardiovascular is not only blood pressure. There are 3 things. That if there is a vasoactive medication being given, it will be given 1 point. If there are 2 vasoactive medications, 2 points. Lactate between 5 and 11, 1 point. More than 11, 2 points. So this is how you can come to a definition, a conclusion whether your patient is having sepsis or not, and whether there is a septic shock or not. This, I have been following the definition of shock ever since I started doing critical care, which is almost 40 years now. This is probably the best that we have had. So much more practical and so much more applicable to the bedside. Of course, it needs a few measurements, but if suppose PaO2 F5 ratio is not there, SpO2 is always available, pulse ox is always available, and we can take these values. Similarly, if lactate is not available, even without lactate, you have alternatives. For example, you can use the neurological status. If Glasgow Coma scale is less than 10, you get 1 point. If fixed dilated pupils, 2 points. So this is how we will come to conclusion whether the patient has a shock, septic shock, or just sepsis, or neither. Once we have defined that, this is where we can look at our patient and follow this. If it's an unwell child with a suspected infection, we screen for sepsis. Sepsis is suspected clinically. Yes, assess for organ dysfunction. If there is, and of course, these are clinical considerations that there will be an antibiotic required and organ support will be required. When you are suspecting an organ dysfunction, apply your Phoenix score that I just showed you in the previous 2 slides. If criteria are met for sepsis, then we'll call it sepsis. And if the cardiovascular dysfunction is also there, we'll say it meets the criteria of our septic shock. This is a very good algorithm to go with the last 2 slides. And here on the right side, I've written the Phoenix sepsis score is not intended for early screening or recognition of possible sepsis and management before organ dysfunction is over. It is to be applied once the organ dysfunction is already there. Then it picks up the septic shock. What is the pathophysiology that leads to what we have talked about in the last 2-3 slides? What happens is that cardiac output we know is dependent on the stroke volume and the heart rate. Stroke volume multiplied by heart rate gives us cardiac output. But cardiac stroke volume itself is dependent on 3 elements: the preload, contractility, and afterload of the heart. Preload means how much blood is coming to the left ventricle in via the left atrium, to the right ventricle via the right atrium at the end of a cycle. That is the preload. And how effectively it is ejected out by the myocardium is contractility. And how much resistance is offered by the let's say the valves and the aorta and the aortic and the arterial bed is the afterload. So afterload is what, if it is high, the stroke volume will become less. Contractility, if it is high, stroke volume will be better. Preload, if it is high up to a limit, stroke volume would be better. Beyond a limit, if preload becomes too high, then according to the Starling law that we all are familiar with, the stroke volume will reduce. Now, once the cardiac output has been talked about, then this is what will determine the blood flow to the systemic circulation and, of course, to the pulmonary circulation also. This will decide how much oxygen is being delivered to the tissues. But that is dependent not only on cardiac output, also on what is the content of oxygen in the blood. And content depends on the hemoglobin concentration, oxygen bound to hemoglobin, and the formula is that you multiply this by 1.34 and add the oxygen dissolved in plasma. That will become the total oxygen content. Oxygen content multiplied by the cardiac output gives you the oxygen delivery to the tissues. Our aim in treatment would be to increase this oxygen delivery to the tissues. This is same thing more or less shown diagrammatically. That heart is there, it is receiving the inputs. This is the preload and it contracts. What goes out is the cardiac output. From the right side, it goes to the lungs, oxygenates, comes back to the left side, and then goes into the whole of the. This is the oxygen delivered to the tissues. Then this is what the tissues have now reached. What they take out of this is called VO2, which is oxygen uptake via the tissues. So DO2 is delivery to the tissues, and suppose tissues are not extracting, or for example, that can happen in, let's say, cyanide toxicity. Then VO2 would be low, although the DO2, the delivered oxygen, is good. So we have to talk about the uptake and the demand also. So it is a measure of the oxygen consumption of the tissues. And whenever the oxygen consumption is less than what is the minimum requirement, MRO2, minimum requirement oxygen, we'll say the patient is in shock because the patient's tissue bed is not getting even the minimum requirement oxygen. So this is the background on which we shall be talking of our management. Now, this is another concept that we have to go into before we really talk about the treatment. Let's start from the right side of the diagram. Normally, the DO2, which is on the horizontal line, and the VO2, which is what is being extracted out by the normal tissues, is not dependent on how much is being delivered, because there is so much more that is being delivered than what is to be taken by what can be taken by the tissues. So when the DO2 goes on decreasing from right to left, till it reaches a critical point, B, there is no problem for the tissues. But when the DO2 reaches less than the point B, then the VO2, that is the oxygen extracted by the tissues, becomes dependent on the supply, and this is where the shock starts. This is the critical oxygen delivery point. And this is what happens once it is supply dependent. Now, SVO2 or SCVO2 is what we can measure. Let us say if we have a central line in the internal jugular vein and we look at the oxygen saturation of that blood, that is what is called the SCVO2 or the SVO2. If it is less than 70%, that means the body is extracting out too much oxygen, and we have already reached a stage where it is oxygen dependence has started. The dependence on the delivery has started. When it is more than 70%, till then that dependence is probably not there, unless suppose this is mainly blood coming from the brain, in the internal jugular vein. If it is a patient brain dead, this can happen that it is more than 70%, and yet the patient is in shock. Now, to assess everything, ultrasound is a great new modality, and new in the sense that it is the last 10-15 years that it has come in the hands of intensivists and pediatricians. What it can tell us is, if we keep it at the chest, in the heart, and so on, we can make out the lungs status. Suppose this kind of status is there, we say there are a lot of B lines, that means child is in pulmonary edema. And similarly, we can look at the inferior vena cava. When the inferior vena cava is dilated, that means the patient is overfull, has too much fluid in his intravascular compartment. If it is too thin and is getting too small during inspiration, expiration, that means it is something that needs more fluids. We say it is fluid responsive. So that way we can get a lot of information. And also we pediatricians can also, even without much of training, can make out whether there is enough contractility of the myocardium or not. And if you train yourself more, you can actually work out at least approximately what the cardiac output and what the cardiac index is, even on the bedside in the hands of pediatricians. So by all these methods, we can come to what are the signs of shock. Tachycardia, tachypnea, blood pressure can be normal in early stages, but lactate rising, or there can be delayed or instantaneous capillary fill time. CFT, feeble or bounding pulses, central and peripheral. Peripheral temperature versus core temperature difference of more than 2 degrees. That means core is the rectal temperature, peripheral temperature may be the axillary temperature, or a temperature being sensed by a temperature sensor, let's say on the chest of the child. Cold and mottled skin, depressed sensorium, reduced urinary output. These are the points that these are the things that you can look at bedside without any much training, without much of monitors being required. So this is what CFT is, that you kind of press for a few seconds at the periphery, release, and see how quickly the blood returns to that area. In cold shock, it will be more than 5 seconds. In warm shock, it will be flash. And normally it will take 1 to 2 seconds. Oops, yeah. By doing all this, what are we trying to achieve? When we have seen what are the problems that are there, what are the pathophysiological problems in a child of septic shock, then we have to decide what are our therapeutic endpoints. And then we'll come to how to achieve those therapeutic endpoints. Capillary refill less than or equal to 2 seconds is one thing which is very easily measurable. Normal pulses with no differential between the quality of peripheral and central pulses. That means both should be strong. Warm extremities. This sometimes takes time, and especially in winter months or even in summer months, if the ICU is too cool, this may be a deceptive thing. We have to be careful. Urine output greater than 1 ml per kg per hour. Again, we have to be very careful in reading this because if you suppose put the urinary catheter now, after 1 hour of treatment, you have given some fluids already. The urine that comes out, you don't know whether it is because of the fluid that you have given or it was lying there for the last 8, 10, 12 hours. The child has not passed urine. So what comes out first time is not the indicator. After that, you can keep measuring every hourly and see whether it is at least 1 ml per kg per hour. Normal mental status, or at least improving mental status to the level that it is almost there. But if suppose patient has meningitis and that is a cause of septic shock, then that will take time. Similarly, if the patient has, let's say, associated sodium abnormality, it can take time. So again, for each one of these points, we have to look at the caveats. Normal blood pressure for age, only reliable when pulses are palpable. So if pulse is not palpable, whatever your monitors are saying, unless you are measuring the invasive blood pressure. Normal glucose and normal ionized calcium concentration. Ionized calcium concentrations are always a part of the blood gas analysis that we do. Of course, biochemistry lab can also give you that. And many of our hospitals, the turnaround time can be less than 1 hour. For management, this, according to a textbook, was VIP, ventilation, infusion, pumping. I thought ventilation can wait. It should be IVP. Infusion of fluids is the single most important intervention that we can do in a patient with septic shock, and the earliest intervention. And many times they will not require ventilation. They may require just a little bit of oxygen and may start getting improved. And of course, third would be pumping or inotropes. The heart has to pump enough so that enough goes to the tissues. I talked about the DO2, the delivered oxygen, and the VO2, the oxygen taken by the tissues. This is the algorithm given by the survival sepsis guidelines in 2021. It still stands as the most updated one. So let's go through this. Let's look at this clock here. Within 1 hour of initial recognition of septic shock, what we have to do is these points. First, obtain an intravenous or an intraosseous access. We all know that if intravenous access cannot be obtained within a minute or two, intraosseous is very easily obtained by the appropriate needle. If you do not have the intraosseous needle with you, even the usual bone marrow aspiration needle can work, provided you have pushed out whatever little bony tissue has come within it by the stillet. Collect the blood culture. This is something very, very, very important. It is said that mortality goes on increasing by something like 9% per hour if we delay giving antibiotics. So blood culture, so that you can give empiric broad spectrum antibiotic. If you have a clue somewhere, for example, a child has, let's say, necrotic pneumonia, and with that has gone into shock, you know that staphylococcus has to be covered. Similarly, if he has an abdominal problem, that you know that gram-negative would be the most common. Suppose the patient has got already splenectomy, we know that pneumococcus will have to be covered, and so on. Similarly, if we go to, then we have to measure the lactate also. If we can do it in 1 hour, very good. Administer fluid boluses if shock is present. We'll go into far more details here into this aspect. Start vasoactive agents if shock persists. And if you have suspected sepsis, there it was that you have clearly said septic shock. Then all these 6 points within 1 hour. If you had suspected sepsis, but patient is still not in shock, then you have 3 hours for this. Expedited diagnostic evaluation has to be done so that you can make out by your lactates and such things if the patient has got shock or not. Diagnostic evaluation supports sepsis-associated organ function, then go organ dysfunction, then go to all these points. So if there is no shock at the time you have more time. But if you have septic shock signs already, your initial score was more than 3 of the Phoenix definition, then all these must be done within 1 hour. Respiratory support, assess of pediatric acute respiratory distress syndrome, infection source control. That means if the patient suppose has an abscess somewhere, it has to be drained. If there is fasciitis, it has to be drained. Continuous reassessment, fluid and vasoactive titration up and down, whatever is required. Advanced hemodynamic monitoring if shock persists. Plus minus hydrocortisone for refractory shock. We'll discuss all these points. Nutritional support, avoid hypoglycemia, give antimicrobials using the stewardship guidelines. Via venous, veno-arterial or veno-venous ECMO can be done as a last resort. So this is the overall protocol for being followed by those patients who are in septic shock. We will go into more details. Now, most important, I told you, is the algorithm for children who have septic shock, how to give IV fluids. Now, we taught before this 2021 guidelines or earlier that within 1 hour, we have to give lots and lots of fluids 20 ml per kg, 3 boluses, and if in 60 minutes patient has not improved, then you start inotropes. But imagine a child who's got, let's say, 40 kg, or let's say 50 kg. Many children of this age also come to us. 50 kg child would need 3 liters of fluids within 1 hour. Have you ever given? But most of our patients do get well, even when we give far less. So there was a large study in African countries where conditions were even worse than what they are in our country, that is more malnutrition, more malaria, and more sepsis. There they found that if you're giving this kind of fluids, they were doing more harm to children than what would be there if you gave lesser amount of fluids. This study had enrolled lakhs of patients. Nobody could deny that what they are saying is right. Even our Europeans and Americans had to bow down to them, and they changed their guidelines. And this is what it is today. So let's take up the left side. Healthcare system with intensive care, and the right side is healthcare system without intensive care unit. Remember, most of our patients are in this milieu. There are no ICUs there. But if the ICU is there, what we have to do is abnormal perfusion with or without hypotension when it is there. That means you may not be able to measure the blood pressure accurately. If signs of fluid overload are there, are absent, administer only 10 to 20 ml per kg. Repeat assessment of hemodynamic response to fluid and consider another 10 ml per kg until shock resolves or signs of fluid overload develop. And what are those signs of fluid overload? If the patient who did not have crepitations now starts having crepitations. If the patient's liver was 1 centimeter when he came, now it becomes 3 centimeters. These are indicators that fluid overload has occurred. Of course, if you have access to, like you would have in ICU, to an ultrasound, now your IVC, the inferior vena cava, which was collapsed, has now become too full. That means you are given too much fluid already. Assess the cardiac function by those methods. And if things are not better, consider epinephrine if there is myocardial dysfunction, or epinephrine, norepinephrine if shock persists after 40 to 60 ml per kg, or sooner if signs of fluid overload develop. That means if you are given 40 to 60 ml per kg, patient is still in shock, myocardium looks good to you on the ultrasound, you will get probably norepinephrine, especially if the pulse pressure is wide. Or you can use epinephrine. If the cardiac function is not good on your ultrasound, what we would call echocardiography, then epinephrine is the drug of choice. Now let's go to the other side. When healthcare system is without intensive care availability, and if there is abnormal perfusion without hypotension, and the other is with hypotension. When it is without hypotension, we have to be very careful. These are the patients who can go into hypervolemia and die because of that. Do not give fluid bolus unless there are signs of dehydration with ongoing fluid losses, diarrhea. Then you can give boluses, otherwise don't give bolus. Start just maintenance fluid. Monitor hemodynamics closely. Consider vasoactive inotropes if available. This is when there is abnormal perfusion but no hypotension. But when there is hypotension, we will have to take the chance of giving a bolus, even in these circumstances of no ICU. If signs of fluid overload are absent, administer fluid bolus. If clinical signs are already present, then you may not give bolus. Assess the hemodynamic response to fluid and repeat fluid boluses 10 to 10 ml per kg until hypotension resolves or signs of fluid overload develop. Assess cardiac function if available. Consider epinephrine, norepinephrine, similar to what is there in this side. So fluid in ml per kg should be dosed as the ideal weight of the body. That means some of those in our kind of patients, in our kind of ICUs, you often get obese children. There we should be calculating all according to their ideal body weight, which is dependent on the length or the height of the child. If the shock is resolved by these measures, very good, and the perfusion is improved, do not give more fluids. As soon as the shock resolved, and I told you what are those signs, those goals that we are trying to achieve. If they have been achieved, stop boluses. Consider maintenance fluid. Monitor for signs of symptoms or recurrence of shock. Sometimes they improve, but within an hour or even less, they are back to their big problems. So if these things are happening, hypotension and all this I have defined for you in the previous slides. What to give? Crystalloids or colloids? Colloids are plasma, albumin, dextran, hetastarch, but only thing that we normally give is albumin. And crystalloids, saline ringer lactate fluid, or what are now called the balanced fluids. Red blood cells, only when there is blood loss, you will use as resuscitation fluid. So these are three possibilities. Now, in sepsis, what is this is occurring? That if you put 100 ml of fluid in a patient who's having sepsis, 25 ml will remain in the plasma, 75 ml, up to 75 ml will go into extravascular compartment that will start causing edema of the feet and the body, but is not available to the heart because these capillaries are leaky. On the other hand, in a normal person, if this will not happen, more will remain here. And if you use colloids, which are far bigger, larger size particles, not this is albumin and that is suppose sodium. You know, sodium is just small size. 123 is, and here 153 is the sodium chloride, and here it is 70,000 Daltons. So that big, large size particles, when they go in, they'll remain in the intravascular compartment for longer periods. Leakage would be less, and it is believed on this basis that they should work better. However, that is not always true. Same thing is shown here. That albumin will remain in the plasma for much more than, let's say, dextrose or normal saline. Now, these are some studies which have looked at control trials, which have looked at resuscitation with colloids or crystalloids. And the last one is still going on. Result will be in 2025. These all major trials came to the conclusion that whether you use crystalloids, that is albumin costing you thousands of rupees, or you use a normal saline or a balanced fluid which costs you a few hundreds or even less, results the same. This is what it is said. In today's practice, insufficient evidence exists to recommend balanced crystalloids over saline across a heterogeneous group of ICU patients. Should we give a lot of fluids or liberal fluids? I have explained to you why we have come to restrictive fluids in those patients who we feel are not already in shock, or we are in a situation where we do not have ICU facilities. This is if the patient is not responding to your inotropes also, you have used 2-3 inotropes to the usual upper limit and things not getting better, then should we give corticosteroids? Because it is believed that corticosteroids will make the receptors more responsive to the doses of epinephrine, norepinephrine that you're giving. However, again, it is believed that they may not be working. So still, this is not a regular routine. Although in current practice, in one of these 2023 guidelines, it's a paper, not really guideline. In our current practice, we use 200 milligram per day of intravenous hydrocortisone plus 50 milligram oral fludrocortisone, given the potential benefit with minimal to no additional risk. This is in those patients who have received enough fluids and are still receiving fluids, and they are also receiving good doses of inotropes and yet not responding. Then you would give this kind of dose. Generally speaking, smaller doses than this are recommended. So survival sepsis guidelines, I have more or less covered them. Quickly, I'll go through some of these guidelines, time permitting. So these are recommendations and guidelines, but your own decision making has to be yours on the bedside. So first thing is, this is screen, diagnose, and systemic management should be on the basis of, for a kind of example, that Phoenix guidelines. Lactate, yes, it's useful if you measure it repeatedly. Bundle of care, that means whenever you have to give, let's say, ventilation, shock, there are few things that you should do together. When you do them together, they're called bundles. And you use bundles of care, then the effects are better rather than you using one by one. Okay, blood culture should be obtained as soon as possible. I talked about it. In children with septic shock, we recommend starting antimicrobial therapy as soon as possible. And for adults, this is what was given. For pediatrics also same applies. That if a shock is present, we said within 1 hour. If shock is not present, if possible within 1 hour, but definitely within 3 hours. Empiric broad spectrum antibiotics. Once we know which pathogen, narrow down, follow antibiotic stewardship. Initial ones can be really, really broad spectrum. And these are guidelines given by them for empiric antimicrobial therapy targeted when you have some idea what the pathogen is. Broad spectrum antimicrobial therapy and multiple drug antimicrobial therapy. These are the definitions given here. And then accordingly, you can choose according to these recommendations. In children without immune compromise and without high risk for multi-drug resistant pathogens, we suggest against the routine use of empiric multiple microbial. That means even one is enough if you can use a broad spectrum one. However, if the child is immune compromised, probably 2 should be used. De-escalate as soon as possible. As soon as your child is better or as soon as your lab has given you correct information. Duration, the shortest possible, but in those patients who are immune compromised, show slow response, or you know the bug is, for example, staphylococcus, which takes long, you will give for longer periods. Choice of depending on what the source, what is the organism, you will choose the antibiotic and guidelines are available. Source control is something that must be done at the earliest. If there is a pus lying somewhere, please drain it as early as possible. Similarly, if the patient already has a central venous line, which was there, for example, in a patient of, say, leukemia was under treatment, and now the patient has developed sepsis, stop using it and as soon as possible remove it. If there is fungal infection of the via the central venous line, remove it immediately. If it is not fungal, then and it is bacterial, you can think of using it after giving it rest. Okay, initial fluids, we talked about 40 to 60 ml. We talked about what if the healthcare system has full availability of ICU or not. And why this large trial I talked about is called the FEAST study in Africa. Crystalloids versus colloids, we said both are probably equally good. Colloid, if you have to use only albumin, others can be even harmful. Hemodynamic monitoring must be done regularly, and whenever possible, mean arterial blood pressure is what we should target. 5th to 50th percentile, anywhere 50th may be safer. Warm versus cold shock. Earlier we were told that the peripheries are cold and the pulse pressure is low, is narrow. That means systolic and diastolic are close to each other. We should call it cold shock. And if they are wide pulse pressure, we should call it warm shock. If the peripheries are warm, we should call it warm shock. Now it is suggested that these may not be as we have always been taught. And so advanced monitoring should be done to decide what kind of inotrope the patient will receive. And if we are using trends in blood lactate, they are better. Vasoactive agents, use norepinephrine as first line if the cardiac function is all right. Target a mean arterial pressure of 65 in adults, and I told you in pediatrics there are different formulas. Consider invasive monitoring blood pressure whenever possible. Have a central venous access. Mean arterial pressure is inadequate despite low to moderate norepinephrine, add vasopressin. And if the cardiac function is not good, add dobutamine. But if the blood pressure is low, add epinephrine. And if things are not getting better at this stage, consider adding hydrocortisone. These are the doses for dopamine, dobutamine, adrenaline, noradrenaline, and milrinone and vasopressin. Okay, so this we have discussed in some detail already. Ventilation, they say that you should intubate the child who is fluid refractory catechol resistant shock. That is the general practice. Ventilation should be done in such a way that you do not use drugs which will harm. For example, etomidate will harm the patient. NIV can be tried for a short while. If it is not working, go on to high pressure and expiratory pressures can be given, and we should treat as if the patient has pediatric ARDS. That means use lung protective strategies, and high PEEP. Prone positioning can be helpful in such patients. INO has very limited value. HFO, very limited value. Neuromuscular blockade, yes, when required, use them initially as soon as possible. Use only sedation, not blockade. Corticosteroids, I've discussed. Blood glucose and insulin, if insulin goes very high, let's say 300, 400, yes, if the glucose goes that high, use insulin to bring it down to less than 180. 180, 150 is a good target. Here it is written 140, but generally we do not give insulin till it is 180, considering that God gave us that value of 180. After that, glycosuria occurs. So probably God thinks that up to 180, it is good enough. The body can tolerate. Blood calcium should be corrected as much as possible. Sick euthyroid syndrome does not need levothyroxine. Antibiotics are helpful to bring down the oxygen demand. Early enteral feeds should be given. Parenteral feeds are not as good as the early enteral nutrition. Gastric residual volume, if it is less, don't worry. If it is very high, then you have to give maybe miss a dose or give lesser volume in the next NG feed. Okay, selenium, glutamine, arginine, zinc have no role. Vitamins, not really anything great. Blood products, we told you that if you give RBCs to maintain the blood level at 10, very good, otherwise, no. If the patient is in shock, 10, otherwise 7 is the good target. Platelet transfusion only if you go very low, 10 to 20,000, or an oncology patient or a patient who's receiving ECMO, you might like to give platelet transfusions. Otherwise, generally, they don't help. So these are the main points of treatment. Many patients will go into renal failure, then a renal replacement therapy would be required. And for renal replacement, if the patient is already having a lot of fluids inside, continuous renal replacement therapy, CRRT, is far better than others. But if you do not have that facility, or if it is turning out to be too costly, filters are very, very expensive, then SLED can be used, which is a slow method of giving dialysis using the ordinary dialysis machine. So ECMO is the last resort, veno-venous or veno-arterial, depending on whether it is oxygenation, which is the problem, or the cardiac output. More often it will be the cardiac output. You will have to use a veno-arterial one, which is somewhat more difficult to start. Okay. IVIG, we suggest against the routine use of IV immunoglobulin in children with septic shock or other sepsis-associated organ dysfunction. However, toxic shock syndrome caused by Staphylococcus etiology may be useful. Those with necrotizing fasciitis, again, it may be useful. And those with primary humoral immunodeficiency or immune compromise with documented immune globulin levels, of course, IVIG may be useful. Except for these indications, it is not generally recommended. Stress ulcer prophylaxis, those who are on high risk, pantoprazole should be used, otherwise no. DVT prophylaxis, generally not recommended in small children, and older ones, yes. So that way, I've more or less covered all the aspects of treatment in a patient of sepsis and septic shock. Thank you very much. If there are any comments and questions, and of course,
Any questions or comments from all the participants?
There are 3 questions there. How to calculate dry weight in a child who's obese or overweight? I said height is what is to be taken, and from there are formulas by which you can work out the ideal weight. What about protocol for SAM with septic shock, sir? SAM is a very severe malnutrition, and here the patient is going to be very, very vulnerable to IV fluids. You will not give boluses. And this patient, you have to give broad spectrum antibiotics. In such patients, if you start 2 antibiotics covering gram positive and gram negative, in the beginning till you have a proper answer, yes, it will be a good idea. Then how to get mean arterial blood pressure chart for children? Charts are available and online. You can search for them. And there are simple formulas also in which the height of the child, the age of the child is multiplied by 1.5 and 45 is added to that. And you get the mean arterial pressure. That should be your target. As per Nelson's protocol, should we give epi norepinephrine till 0.3 mcg only, sir? Yes, that is the current definition or current amount that you would give of epi and norepinephrine, where we would say that if the patient responds to this level, you may not need a third inodrop or you may not need hydrocortisone. But if more are being needed, you have to go higher than this, then steroid should be added in the low dose infusion. Sorry. Any other questions? I think, okay. What about inotrope of choice in SAM that we have? Dopa or adrenaline? Dopamine is generally out these days. It is adrenaline, noradrenaline, milrinone, vasopressin, and in a few patients, dobutamine. These are the ones which are used, and others maybe beyond the scope of us pediatricians. Our cardiology friends sometimes may ask us to use something different. Any other questions? I think no more here.
Hello, should I conclude?
Yes, certainly you can give your comments and this thing, add inputs. Maybe Dr. Amresh and others can also join in.
Thank you, Dr.
All of you have a lot of experience with dealing with such patients.
Thank you, Dr. Krishan Chugh, sir, for such a nice and elaborative discussion on this important topic of management of septic shock. I think the most important point in this is very strict monitoring and early intervention. That definitely improves the outcome. I really congratulate Dr. Anupam sir, Dr. Alok sir, Dr. Mukesh sir, Dr. Lalit for starting this initiative for this online program. It's very, very useful for our PG residents and fellows. Almost all the PGs from our institute have joined. Sir, we really want you in Amritsar also in April.
Sure,
so
sir.
please
We'll be there.
kindly try.
Okay, we'll come. Why not?
Sir. Any other comments?
Dr. Chugh, very nice talk. Just one thing, empirical antibiotic will be always in relation to age only, infancy and adult. जैसे हमने blood culture ले लिया and we are suspecting sepsis. So what is your guideline on that? Which antibiotic should be immediately put before after taking the blood culture in sepsis shock?
Generally speaking, our first line antibiotic that we have to start will depend on whether patient is coming de novo to you or has already received some antibiotic somewhere, which will happen very often to us who are having referred patients. Second, is it a hospital-acquired infection or is it a home-acquired or a community-acquired infection? Third, do you have a lead somewhere already? For example, I gave you staph pneumonia already there. Then that kind of antibiotic, and suppose, let's take the example of staph pneumonia again. If the patient is coming from a community, we would expect that it will not be MRSA, but that is not true today. We have to see if more than 10 to 15%, let's say more than 15% of our patients are coming from outside, who are coming from that community where more than 15% are already resistant variety, MRSA. Then when they come to you, you'll from the beginning you start with either teicoplanin or vancomycin. So that is the kind of background that to take into consideration. Otherwise, for example, let's say the patient of typhoid comes to you with a septic shock, monoseph and the ceftriaxone, maybe with azithromycin is good enough.
Right. So it depends on the clinical setting you see the patient and the history. Thank you, sir. Dr. Amresh, any comment?
Sir, thank you, sir, for the wonderful talk. So just one query or one thought from it. As you mentioned, the shock.
Please unmute. Please unmute.
Sorry, sir. Thank you for the wonderful talk, sir. It was a mind-blowing talk. As the sepsis definition says, is a dysregulated host response. So are they in the future, is there anything which can regulate the host responses, and whether it's the host factors which plays a major role? Whether is the host factor plays a major role, or the infective agent, which would be, what would be the future treatment?
Yes, yes. We see we more or less have targets by which we can target the the microbes that are there. And yet we are getting high mortality, especially in adults with, say, diabetes, this, that, 30% mortality or even more. So, which means it is the human body whose response we should be able to regulate. A lot of research is going on this. Big money is involved here, and I'm sure things will come. But for the timing, whatever we have is not good enough to be applied on the bedside. I can give you example of one thing which was called APC. It was anti-factor 5A. This came with a big bang by Eli Lilly, and it was used in adults. Thank God, in children it was not promoted. Otherwise, probably we would have also used it. It was used for 4, 5, 6 years. It caused more harm than good. By then, Eli Lilly had made billions out of it because one dose costed more than ₹1,00,000 at that time. And then they withdrew their drug, that it is causing harm. So be careful in choosing new drugs that are promoted. But yes, the future lies there. I agree with you.
Thank you, sir. Thank you for this.
Short comment. As we are moving ahead in life and as we are moving ahead in sciences, you're finding that more and more of the pediatric patients who have an sort of a severe sepsis are turning out to be inborn errors of immune system. Okay, and we should always keep a caution on, because how does the same organism cause a mild disease in another child it causes severe sepsis? So one has to look at those aspects of it, and the number of patients with and the number of inborn errors is increasing day by day. So one will have to think of all those things as time goes and become an expert in those also.
If the time allows, there are 2 more questions. I'll quickly take them. Is there any maximum upper limit of fluid, sir, if there is no ultrasound available? Well, without ultrasound also, as we said, new crepitations and liver size increasing and no urine coming or urine coming, these are the ways by which you can make out whether you are giving too much or too little and accordingly decide. Yes, pulse pressure is the next question, which also is useful in this question of maximum upper limit. What is the pulse pressure? What is the difference between systolic and the diastolic blood pressure to call it wide pulse pressure is a question asked. Now, normally speaking, of the systolic blood pressure that you have, 1/3 is the difference between the systolic and the diastolic, 120/80, for example, and 40 is the difference. So same formula applies for lower blood pressure also, generally. But if you have invasive blood pressure monitoring, then mean blood pressure is measured and not just calculated. So that is a better way of looking at it. Right.
Yes,
I think-
congratulations, sir. Congratulations, Chugh, sir. Excellent presentation as usual. Just one comment and one query, sir, regarding that. You were mentioning in one of the chart of this, where it is mentioned that if the blood pressure is normal, then we have to avoid the fluid, even if the CFT is prolonged.
Patient पूछ रहा कौन?
But in case of the facility where there is no ICU facility, it is very difficult because hypotension is the late sign of shock. So in that condition, and you were mentioning in one of the chart that in that condition we don't require that IV fluid. So ideally, we are
Yes, that is the current recommendation, because they have seen that if you give boluses in such patients, you will dose, let's say, good to 10, you may do harm to 15.
Yeah.
That is the reason why they say that if you go slow, that you will give fluids, but not big boluses. Normal big bolus is 20 ml per kg to be given over 5, 10, 15 minutes. In such situation, give 10 ml per kg and give it, let's say, over half hour.
Yeah, 10
20
ml you can give 10 ml.
Yes, lower and comparatively slow.
कौन सा लगा ये नहीं लिखा हुआ.
Right.
ये लिखवा लो कौन सा लगा, उसमें कवर है नहीं, उससे पूछो
Okay.
ना किससे लगवा.
Dr. Alok, I think, is there any other comment which is there?
Dr. Sanjeev, sir, you want to say something before concluding?
Yeah, it was a very excellent talk by Dr. Krishan Chugh. And septic shock, I think it's very complex subject as well as very challenging. And sir has made it very easy. Like it's like Sachin Tendulkar playing on the ground. You know, things look very simple for the players to play, but then we know how tough the pitch is when other batsmen go in for the to play. So thank you very much, Dr. Kishan Chugh. It was very enlightening from you, and you made the very complex topic simple to understandable. And thank you for giving me opportunity to come before you. Thank you for connecting with the IIP Delhi.
Okay, thank you very much, all of you. It has been a pleasure listening to Dr. Chugh, Dr. Chetty, Dr. Patil, and Dr. Krishan Narang. Thank you very much, sir. And good
Thank
night
you,
to
sir. Thank
everyone.
you.
Thank you. It's been an honor giving this talk. Thank you.
Sir, Dr. Chugh, how are you feeling now?
I'm well now, totally.
अब आप पकड़ लिया मैंने आपको. How are you feeling now? How is your health now? Because
यही हुआ था जो पढ़ा रहा हूँ, यही था.
I know that. How is
I'm
everything?
fine. It was E. coli sepsis, and within hours I was in shock. Lots of problems, but God is great. Helped me to get out of it.
Because आप फोन नहीं उठा रहे थे तो मैंने कहा बीच में that was the thing. Okay, God bless you.
ठीक है. Thank you so much.
Thank you, sir. Thank you very much, and get well now.
Thank you, friends. Thank you, sir.